Good morning. Welcome back. This is Daybreak, and thank you for staying with us. The hashtag on X is Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. We will sample your feedback in the course of this broadcast. With me in the studio is Dr. Davji Atela. On my immediate right, he is the Secretary General of the Kenya Medical Practitioners and Dentists Union. Good morning, Dr. and thanks for your time.
Good morning, Abdikadir.
Dr. Robert Pukose is the lawmaker representing Endebess constituency and as well the chairperson of the National Assembly Health Committee, and he is here with us in his capacity as the chairperson and as well as a professional doctor. Thank you for your time, Dr.
Good morning, Abdikadir, and good morning, viewers.
Much appreciated. So let's begin with what has been the road to UHC, which is the healthcare coverage that President William Ruto has billed as one of his major manifesto pledges, set to, of course, the allocation in terms of just the breakdown of the numbers. The Ministry of Health was allocated in the financial year 23-24 141 billion Kenya shillings, and there are also 100,000 community health promoters who have been deployed to cover 100 households across the country and specific counties where they have been deployed. The Social Health Authority, which will replace the NHIF, the National Hospital Insurance Fund, will have three aspects to it. The Primary Healthcare Fund, which will finance services in the health facilities at level 1 to 3. The Social Health Insurance Fund will cover services at level 4 to 6. And the Emergency Chronic and Critical Illness Fund will fund emergency and chronic illness costs once social health insurance is depleted. We'll be talking about the four pillars to that effect and what happened in October last year during the Mashujaa Day celebrations that was themed universal healthcare coverage as the main agenda for that day. And just previously, a day before that actual day, President William Ruto signed into law bills that were passed by the National Assembly, saying this is the take-off point to address the country's healthcare problems. Dr. Davji, coming to you first. On the 19th October, you were at State House as part of the stakeholders, including Dr. Pukose here, when the president signed the bills into law, and you had expressed your support for what at the time the government said is the takeoff point of Kenya's universal healthcare coverage program, but you thereafter expressed concerns and even moved to court in November the very same year. What were your reservations thereafter that you established and informed your petition in court?
Thank you so much, Abdikadir. You see, before bills are enacted into an act, there's a process of public participation, which was then both at the Ministry of Health, which was done internally, and also done by the Parliament. Mm-hmm. We gave submissions on the issues or the parts of the articles of this particular bill before it became an act. That after it was enacted, we realized that all these submissions that we had done to the Parliament were not considered. For example, there's a transition clause, number 5, that states that at the appointed date, the Social Health Insurance Fund or Act will not provide comprehensive medical scheme or benefits to all those who are providing. In our submissions, we had indicated the value and the need to have that provided. Again, also, we had also in section 26, 5 of the Act, we had already indicated that it is unconstitutional to deny Kenyans services both in the counties and national as part of the bill. That again was considered. It was not removed in the Act. We had also indicated that there should be clear parameters before the claim management is privatized. It's given to private insurance companies, because in the bill it was indicating that the claim management shall be outsourced to institutions or to insurances that were being regulated by IR. So we had also put that into context. It was not considered. We also brought that the members of authority, Social Health Authority, none of them comes from a public sector. So we said public sector is a key stakeholder in the social health authority in the social health insurance. And therefore, there's need to consider them being part and parcel of the authority. That was not considered. And therefore, when we looked at all those aspects, we realized that it was actually not that all the issues we had brought at the submission were just like academic exercise, public participation that was organized by the parliament. And we came to realize the whole thing was maybe a manipulation, because then, and again, we just did submission. We were not called for hearing. The parliament did hearing in Machakos, and the Senate did a hearing in Turkana. So we knew that based on the hearing that we were doing, probably the submissions were done in writing will be considered for this particular act. After it was signed, we realized all that was out. And the ramification of that was quite heavy, because if you look at it, that the comprehensive schemes that we were getting from NHIF was not a favor. The civil servants and the parastatals actually relinquished and stopped giving medical allowance to the workers, and that's why they were getting this medical comprehensive cover. And also, that's the basis of our moving to court on these matters. So
you did not appear before the Health Committee during the public participation exercise?
They did not call us for any public for any oral submissions, but we did our submissions in writings, which were not considered, and the reasons why they're not considered was not given.
Okay, because the chairperson is here, Dr. Robert Pukose, sorry. We'll talk about what appears to be the deeply held belief. Of course, looking at the structure of how this has been broken down, looks very well on paper to address some of the healthcare problems in the country that we have been having in the previous administrations as well. But are there parties that didn't appear before you, and have you considered all the submissions that have been made to your committee during the public participation exercise, and what were you able to pick out?
Thank you, Abdigadir, and thank you, our viewers. In public participation is one of the requirements by our Constitution, that public participation must be done. And public participation will involve either oral submissions or written submissions. When written submissions are given, you'll find that the committee will go through all the written submissions clause by clause. And that is what we did for the Kenya Medical Practitioners and Dentists Union. And if we thought there was anything that we needed clarifications, we would have invited them. But at that stage, we didn't think it was necessary to invite them, because it was clear what they stated. In public participation, it doesn't mean that everything that you say will be taken, because some of the proposals that you make could have substantial implications. It could change complete structure of the bill, because when bills are done, you'll find that there is a certain aim in which you want to achieve through that act. If the submissions that you give will now be able to will change the whole structure of the bill, then it will mean rewriting the bill again. Let me respond to what Dr. Dafche talked about. When you talk about comprehensive health care, actually, this bill the act provides comprehensive health care. Because, one, you'll find that now, initially, we didn't provide for coverage for level 1, level 2, and level 3. In this bill, you have providing for coverage for that level 1, level 2, level 3 through the primary health care
fund.
Primary health care fund. When it comes to level 4, level 5, level 6, then you'll use the social health insurance fund. When that is exhausted, you still have another fund, which is the emergency, chronic illnesses, and critical care. Because more often, people who have exhausted, that they have exhausted their fund and needs comprehensive, means you require more treatment. You've exhausted your fund. What is more comprehensive, more than somebody you have exhausted your social health insurance fund, and I can access. If you are diabetic, you are hypertensive, you are a renal patient, you can still access services from all hospitals. What needs to be done is we need to work on our regulations to look at what is this that is going to cover. That is not supposed to be done in the Act. It will be done in the regulations. And what Dr. Dafji is saying, that's what you need now to look at, is to look at the cover. What is this cover that is going to cover? So that you can now be able to take your opinions to the ministry, which is now in the process of carrying out public participation. And we look at this, what is this that we are calling comprehensive cover? What is it that we want any Kenyan outside there? And you know, so this is a social health insurance. In social health insurance, it means it is covering for everybody. If you think you need more cover, him who is a doctor and myself who is a member of parliament, a legislator, and I need more cover, I can add and maybe go into add another private insurer so that I can get more cover. But for this social health insurance, which is for every public, we must make sure that we are fair and have services which are accessible to everybody. When you look at the other issue which he raised, about that in this act, he realized that it is saying that the social health insurance, the insurance will be able to be they'll be able to be recruited or to be outsourced by the new social health insurer. They brought an amendment saying we should make it may, which the committee agreed. That if there are services that cannot be able to be done, we've not said it shall. Actually, when you look at the act is saying it may. Meaning, if the social health insurance authority feels that we have services which we can outsource, and we are not able, because you see, currently the Committee of Health is investigating fraud, which has happened in the NHIF. Some of that fraud has been a collision between the hospitals and the NHIF staff. Now, when you have that collision, do we think we should continue doing it the way we've been doing, or we can have somebody else who will be able to look at the claims management, access, and make sure that these claims are properly done, go into the hospitals and make sure that those services are done, and then send it to evaluate and send it to NHIF so that NHIF can pay.
For processing of the
payment. Processing. The last one.
Yes, Dr. I take your point because we need to go on a break and come back. And also, in the course of our discussion, Dr. Davji and Dr. Pukose, from the Health Cabinet Secretary, Susan Nakhumicha, on the capping, because she said that's open to public participation on private hospitals, what you have mentioned, the NHIF pitfalls where the problems were in terms of corruption and mismanagement, and also in terms of premium, and why the sudden rush, according to many Kenyans, and holistically look at this and whether it's the cost correction point of our healthcare system. And I'm sure Dr. Davji will be interested in coming back on that point after the break here on the broadcast. And as we welcome your contributions as well here on Daybreak, the hashtag on X is Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. And after the break, we'll be joined by Dr. Brian Lishenga, who is the chairperson of the Rural Private Hospitals Association here in the country. And we'll sample your feedback here in the course of this broadcast. Stay tuned.